All right. Take it away, Hans. Hans, you're muted. I'm sorry.
Thank you very much. I'll start with the chief complaint and the one picture that I have. Okay. The chief complaint is I have a mom who brings in her 4-month-old baby girl, and this baby girl developed an annular, scaly, plaque-like rash over the face and abdomen. And I'll stop here and I'll show the picture before we continue.
Um, Exciting. As someone who works at the U.S. Veterans Hospital, I see such cases all the time. Um, not really. Oh, poor baby. Um, Steph, do you want to tackle this first, or me,
Sure.
or should we trade off every other word?
No, I'm happy to share some thoughts. And yes, we'll heavily lean into the pediatricians on it, the other parents on it. Thank you, Austin. Yeah, even parenthood prepares you for some rashes. So I guess a couple things to say. New babies get rashes all the time, usually benign. They appear and they go away. I think a key branch point early on, as we get more history from the baby's mom, is this seem to be bothering the baby or not? Is it symptomatic or not? If so, what are the other associated symptoms with it? Are there fevers, irritability, difficulty eating, etc.? Um, because I think knowing whether this could be part of a systemic illness versus a primary dermatologic disorder is just an important standpoint, really not just for pediatrics, of course, but with all kind of rashes that we see in patients in general. Um, Hans, the distribution, you said it's on the chest and belly and then also the face. Okay.
Yes, it started, the HPI will be telling you,
Okay.
it started on the face and then the belly.
Okay. So I think kind of things to think about kind of early on are sort of what are the common, benign categories of rashes in young little kids. There's of course, right, contact related things, which this distribution doesn't look like. Little kids can get superficial dermatophyte affections. And then little kids, of course, can get sort of some of the allergic dermatoses that then continue throughout childhood in the eczema category. I think knowing that the baby's 4 months old, it's important to think about what vaccinations, she hasn't gotten yet. And so, babies don't have not had a lot of their vaccinations against preventable illness at 4 months of age, right? Including things like measles, mumps, rubella, et cetera. So again, whether there's a systemic syndrome will help us think about if this baby's at risk for an infectious etiology, whether vaccine preventable or again, all kinds of viruses cause viral exanthems. Now, the fact that this rash is kind of annular and plaque-like doesn't fit as well in my illness script of viral exanthems specifically, but is generally right a category that kids are at risk for. I think the one other comment I'll add before seeing if Zavan has other thoughts is besides the history of systemic symptoms, what else to look for in an exam. And so knowing, right, if inside the mouth or on the tongue there's lesions or whether that's spared, again, can help us work through some of these categories. Do you have other thoughts, Simon?
Not a whole lot. Yeah, I agree. I think whether there's it's sort of like just rash and the baby's feeling well versus rash plus fever, right? Or like rash plus baby sick is a huge branch point. And then the other just sort of thing that stood out to me just on the picture is yeah, the distribution, how it's in a lot of different places. And yeah, you can have tinea, which saw in the chat was sort of like a lot of people's first impressions too. Um, tinea can happen. You can have multiple lesions, but I think the scale is something that makes like a fungal infection, I guess, more raises a little bit, right? But what it looked like to me, and Hans, feel free to just sort of like reshare so we can see a blown up picture again. Like some babies, and honestly, some people, anybody, can just have like dry skin that can seem a little scaly everywhere, right? And I think that's sort of an important differentiator is it a scaly rash or is there just some scaliness on the skin because of, xerosis or kind of like a baseline eczema on top of which there's a new process, right? That can kind of confuse you and make you think that it's a scaly process but when it's not.
And I see in the chat, Lucas is kind of wondering about risk for congenital lupus, just knowing the distribution, which I think is an important thought. We'll hear more. Obviously, not super common in kids, but what's interesting is neonatal lupus, right? It's from the passive transfer of the autobodies from the mom. And so those autobodies are transferred at birth. But the reason the rash most commonly comes on later, usually the order of weeks as opposed to months, unlike this case, is sun exposure. So I think just generally kind of knowing about sun exposure recently with this in particular can again help us think not just of neonatal lupus, but just other kind of photosensitive rashes that might kind of become more apparent as there's like photo exposure on the kid.
Um, Yeah, Steph, and actually, Hans, just so we know how to time the discussion, like, how many aliquots are there, or are we mostly just sort of like doing like a visual diagnosis of this rash?
I have fought aliquots, and I think it's really very fast.
Okay. Well, I guess I just wanted to also like just I don't know if there's any dermatologist or pseudo dermatologist or aspiring dermatologist, but to yeah, kind of give a nod to sort of the importance of kind of characterizing the lesion, primary versus secondary, and I think the annular right appearance of the lesions is an important kind of part of the problem representation. And if there's sort of a potentially an additional area of erythema within the annular, right, sort of further characterizing it as sort of potentially targetoid lesions would be just an important framing to kind of build the uh, uh, differential diagnosis and then sort of like listen for the context or clues that may help to narrow it further.
I think then I'll continue with the history of present illness. And yes, the mother noticed the rash, the annular plaques, over the face first and later on the belly 1 month ago. At first, the rash appeared with sun exposure, but later the rash spread to the belly. Other than the rash, the baby is doing fine. The baby was born following a normal pregnancy and delivery and is the first child for her family. The mother denies exposure to pets, and there has been no contact with people with fungal infections as far as she knows. If you like, we can continue with the past medical history, or we can stop here for a discussion.
I think we can mostly continue, but I think as we were sort of querying in the chat with some other people's questions, right? There was a sort of sun exposure onset, but right, spreading then to the belly, where presumably this baby's been wrapped up or enclosed, so is kind of including non-sun exposed area at this point, and it's good to know the baby's doing well otherwise, right? It makes it kind of less likely that it's some of those, as we talked about, systemic illnesses, viral illnesses, et cetera.
Yeah. Um, yeah, I guess like just how much do we think of this now as like kind of photosensitive, right? And sort of think more strongly about neonatal lupus. It's hard to say. I mean, most babies don't get a ton of sun on their belly, right? Um, but yeah, kind of uncertainty, and then yeah, sort of the lack of kind of systemic acute illness makes sort of viral or post-viral kind of erythema kind of multiforme triggered by a virus or mycoplasma or something, a little less likely, but still possible.
Then I continue with the past medical history, which of course for a 4-month-old baby is not very significant. There is no past medical history, and the family history is unremarkable. But upon further inquiry, the mom reports that she noticed for quite some time some non-specific joint pain and fatigue. And it comes and goes. And during her pregnancy, the fatigue and the joint pain was almost gone, but it appears that it's kind of coming back again. And then for the physical exam, we could do this in the same aliquot whenever the scribe is ready. The physical exam was mainly unremarkable. It was a joyful child, and there were no pathologic findings except for the skin where we had the rash, and it was a non-blanching rash. Yes, and face and abdomen show the annual scaly plaque as reported by the mother. I can also, if you like, add the first lab values, or we can stop here.
Let's
I think
stop
it's a
here.
good
Yeah,
place to pause. Yeah.
Yeah, go ahead, Zaven. You start things off.
Yeah, I mean, I think it's interesting how sort of you've gone from potentially having one patient to two, right? And I guess that's not, as a non-pediatrician, again, I just don't see this a lot, but now that I'm reflecting on it, that's probably not a rare situation in pediatrics, and especially kind of in infancy, and especially if the patient's breastfeeding or if the kid is breastfeeding, right? Because of both potentially vertically transmitted infections, vertically transmitted like pathogenic antibodies versus protective antibodies, right? Through the breast milk, potentially transmission of medications through breast milk, all of which could influence the health or illness of an infant, and all of which relies on understanding the medical history of the mother, right? So yeah, I guess we should sort of wonder and ask more questions now to the mom about whether there could be a syndrome beyond just arthralgias that would increase suspicion for maternal lupus. I think that last little aliquot is kind of that's what made me think more than anything else. How about you, Steph?
Yeah, I think it's interesting being adult physicians, right, who have single patients, but yeah, for OBs and maternal fetal medicine, right, they're always thinking about two patients at once, so it's just sort of a different exercise. But I think you link together, right, why the pathophysiology of one would affect the other person in this case. I think if we were to sort of pull out the mom's sort of chronic fatigue and joint pains and think about how that overlays right with this neonatal rash, I think we would like broadly think about kind of both autoimmune condition kind of pathophysiology for polyarthritis. We could think about kind of chronic infections too that could have maternal fetal transfer, right? Hopefully syphilis testing is done as part of the routine prenatal care, but I think important to sort of think about here also. So with really kind of, rheumatologic and untreated kind of chronic infectious conditions probably being the best categories to think about for overlaying the mom's kind of chronic constitutional and joint symptoms with what the baby's going through. So I think sort of thinking ahead with next steps, just with that very broad differential diagnosis, we'll see what Hans gives us, but I think, right, basic labs for the baby will be helpful. I know, right, we very sparingly get lab values in babies, but a CBC that shows cytopenias, for example, or any liver abnormalities, right, is going to make us think more of these systemic categories that we've thought about, and whether there's enough now to check for Roe and Law in the baby, right, for this question of neonatal potential risk for neonatal lupus, which are the antibodies that cross the placenta and cause this, is valuable. And if that is a diagnosis, we're going to think more about getting an ECG for the baby to make sure there's not kind of congenital conduction block there will be important. But I think the routine things need to be checked also, including the sort of syphilis serologies. Do you have a wish list, Zaven, on other kind of next info based on the differential we built?
No, but no, I think I totally agree. I mean, it's even if our suspicion is low, um, from my faint recesses of memory, I feel like the diagnosis is important enough that the testing threshold should be low. So I think
Yeah.
checking for SSA and SSB and an EKG for to sort of make sure there's not a heart block is would be worthwhile. But you just reminded me that the antibodies cross transplacentally, not through lactation, which makes
Yeah.
a lot more a lot more sense. Um, yeah.
And then I'll continue with the lab values, and they are just as easy as the physical exam. CBC and chemistry were all unremarkable. A liver panel was unremarkable. And at this point, I can ask maybe the audience what other tests you would like to do, or I'll just mention the ones that were done. I think it's already been mentioned several times before by Steph and Zaven later on. We did a serology was done as well because the rash looked pretty much like neonatal SLE. So they did an ANA, which was positive, an anti-Rho SSA, which was positive, an anti-LA SSB, which was positive, and an anti-U1 RNP, that's dermatomyositis mixed connective tissue disease, which was positive as well. And that will just lead us straight to.
You muted yourself, Hans, just after you said straight to the.
Yeah, I think the last tests, and you mentioned them before, they probably give us a good clue of what the diagnosis could.
Yeah. Um, and Hans, could you also just clarify these antibodies were checked in the baby, the mom, or both?
Uh, at first in the baby, and then we had our real patient, which was the mom, and it was checked in her as well.
Wow. Yeah, I mean, I think those antibodies, especially in this context, are very specific and kind of um, clinch the diagnosis of neonatal SLE and sort of uh, similar process in mom. I think it would be very important to kind of go back to mom and do a very thorough review of systems, not just like now, but to kind of go back into the past on a scale of months to even years to see what kind of odd, fleeting, or persistent symptoms she has had that hadn't been previously explained, whether those are, you know, the ocular, GI, pulmonary, cardiac, dermatologic, systemic, you know, anything that could potentially kind of be contextualized and explained by this process. You know, lupus, I think, can get worse during pregnancy, right? As opposed to rheumatoid arthritis can sometimes get better during pregnancy. Or can somebody fact check me on that? Um, but um, but anyway, I think it would be important not to miss kind of organ manifestations in in our adult patient, and of course that sort of both based on history and physical, as well as kind of certain screening laboratories, right? The patient um, needs at least a UA, if not further kind of renal investigation, and uh, yeah, and if there's sort of symptoms, potentially going on to do further targeted diagnostics to better define the extent of illness and thus inform management and things like that. And then as far as like how you manage the baby situation, I have no idea. Uh, Other than I can guess, sun avoidance may be important.
Yeah, this is exactly what they did. Sun avoidance, and then we just wait until the antibodies are broken down over time, and the baby should then be okay. But the mom was then subject of further investigation, and of course, the same antibodies were found in her blood naturally. Anna was positive, but anti-Smith, I'm not aware. This was probably negative, but the other ones, anti-Rho SSA, anti-LA-SSB, and anti-U1 RNP, they were all positive. And a rheumatological workup then diagnosed the mom with mixed connective tissue disease. And it was considered subclinical with only showing very mild symptoms of joint pain. Now, when she needs further treatment for her condition, I cannot say. Usually, when it's subclinical and she doesn't complain a lot about it, we just wait with treatments and observe the mom over time. And that was the case. I mean, I was almost sure that you would find the diagnosis almost, and or it would be mentioned at the chief complaint. But it was the first time that I saw something like this, where I thought, oh, what could it be? A child with a rash. And then I looked at all possible childhood rashes. They are usually benign, but not all of them, because we could have viral infections. And yes, the child just inherited the antibodies from her mom and was healthy.
Thank you.
Wow.
I think this was a great, yeah, exercise, both just sort of out of our comfort zone, but you know, a case that really drives home how important family history is, right? And what symptoms are happening in close family members, and just very interesting pathophysiology. This is a completely passively transmitted autoimmune disease, which can be bad, right? The effect on the skin and then the heart. I presume, Hans, the baby had an ECG that looked okay in terms of conduction. Um, and then it's a waiting game until the autoantibodies go away, which is really just kind of interesting. And then, as far as I know, yeah, that doesn't confer any increased risk for the child growing up. I'm wondering if anyone, so the ECG was normal. That's great. This anti-U1 RNP, when it comes to kind of neonatal lupus specifically, I don't know if anybody looked up. I have that in my mind as like an association for higher kind of risk of transmission for neonatal lupus, but wasn't sure. Yeah, it's something that I have to look at, but thought that had a particular association for kind of the risk in this baby getting this. Other reflections, Abid?
No, amazing case. Thank you, Hans, for bringing it to us. I'm actually just kind of curious to hear and invite like Manaswini. Thanks for kind of commenting on the sort of pregnancy uh, exacerbation. I don't know if you can or want to say any more about that, but I'd love, or if anybody else sort of like knows or looked up any other kind of related teaching points to just consolidate um, some other interesting or important information, because it's yeah, it's not something that I've thought about a lot.
Same here. That's why I was a little bit surprised. I never had such a situation or patient. But we see all kinds of people in our walk-in clinic where I am.
Um, wow. So yeah, anybody want to let's see. Thank you. Did a quick search. So autoimmune diseases driven by Th1 and Th17 immune responses tend to improve during pregnancy, while those driven by Th2 and humoral immunity tend to worsen. Pattern reflects the physiologic shift from cell-mediated Th1 dominant to humoral Th2 dominant immunity that occurs during gestation to maintain fetal tolerance. Wow, that makes sense, and that's amazing. Thank you, Mandy. Mohammed, do you want to summarize or highlight everything we discussed, and bring us home?
Thank you, Hans. Thank you, Hans, for this case. It was amazing. So we started discussing about the rash in a newborn, and we said that the rashes, most of them are benign rashes. So we have to look for red flags, whether they are fever, systemic symptoms, ill-looking child. Also, we looked at the vaccination history of the child, especially for viral enzymes, and also sun exposure. Then we have looked at the scales and the characteristic of the rash, the distribution, and we want to differentiate the scales, whether are xerosis or it is truly scaly rash. Then from the information about the mother history of arthralgias point us towards working and looking at the mother history at two arms. First, the breastfeeding. It can transmit either infections, antibodies, and medications could cause this rash, or explore further the syndrome behind the fatigue and recurrent arthralgias. And after workup, positive serologies, ANA, SSA, SSB are very specific for neonatal SLE. And also we consider the EKG for looking for conduction block. Thank you, everyone.
Thanks,
Thank you,
Mohammed.
Mohammed.
I just
Thank
wanted,
you, Hans.
I just looked two things up quickly. I wanted to correct myself in saying the kids don't have, it doesn't seem like they can have a higher risk of developing overt lupus, but I looked briefly, and other autoimmune conditions can have a slight increase. Now, whether that's because they had neonatal lupus or they're just family history in general, I didn't look deeply into that. And then I was just thinking, for this young woman or the mom, right? This was her first baby. So if she chooses to have another one, what's done? And it looks like hydroxychloroquine is used and safe in pregnancy to actually prevent neonatal lupus when a woman who's had a kid with it the first time does it. So very interesting to think about how this is managed in subsequent pregnancies. Really great case, Hans. Yeah, short, sweet, very interesting, though. A lot to discuss. Really enjoyed it and appreciate everyone's time here today, as always. Have a great
Thanks,
rest of the
everyone.
day.
Thanks, Mana Sweeney. Bye.
Bye.